So another topic that you've mentioned is permissive hypotension. That is, and I always looked at it as the more air a tire's got in it, the faster the air leaks out.
That's right.
So kind of give us your thoughts on permissive hypotension with the trauma patient and where we would go with that.
I think permissive hypotension is not a new thing. They've been studying that, especially since they've been looking at, especially since they started, the Afghanistan and Iraq and etc. Which I will say that many of the advances in trauma care are a direct result of the military medicine that we have unfortunately had to embrace as a nation over the last few years. When I say unfortunately, I mean it was unfortunate that we that these people have had all these injuries, but I do think,
and we have to fight to learn stuff in medicine.
But I do think that it is advanced trauma care, especially in the pre-hospital arena, more than anything that we've had in the last 50 or 60 years. But the permissive hypotension, if you look at that, it really only applies to penetrating trauma. There's some pretty fair evidence that that permissive hypotension is something that we really ought to embrace for penetrating trauma. It has not been quite as well studied in blunt trauma, and traumatic brain injury is something that we need to throw out the window when we start talking about permissive hypotension, because we don't want those people hypotensive. But if you look at penetrating injuries, gunshot wounds, stab wounds, etc., those people, you really should shoot for a blood pressure of 80 to 90. So as a general rule, if you can get that radial pulse, and you palpate that radial pulse, that's where you probably should shoot for it, and keep it there. We used to say 100, 110. We don't really do that anymore with penetrating trauma, and the reason behind that is, as we know, many times these people are forming a clot over that injury, or we hope they're forming a clot. Well, if you get that blood pressure up and you get it up to 110, 120, you're increasing the risk of blowing that clot off and causing increased bleeding. Massive amounts of fluid, crystalloid fluid, can cause hypothermia because we're not warming the fluids in the field. And we do warm the fluids to a level 1 warmer in the emergency department, not always, but we really should. 3, because of all the chloride we're given, you can get a hyperchloremic acidosis. So that's something if you're giving massive fluids. And the 4th thing is hemodilution. You're diluting what blood is left, and when you dilute that blood, you're actually decreasing the oxygen carrying capacity of that blood. So you're actually making cellular hypoxia worse. So those are 4 things: blowing the clot, hypothermia, hyperchloremic acidosis, and hemodilution, which ultimately leads to decreased oxygen carrying capacity. So I think those are things. There's some centers, some trauma centers, that are not giving any crystalloids, none whatsoever. If a patient needs fluids, they're given plasma and fresh frozen, either they're thawing this plasma out, or having liquid plasma, which lasts for about 45 days in a cooler. So these trauma centers, when you come in and need fluid, they're not even going to lactated ringers or normal saline. They're going straight to packed red blood cells and plasma. And what happens that we don't, from a pre-hospital standpoint, we don't see and we don't think about is that the more fluid you give, when they do have to open or do a laparotomy on somebody to repair something in the gut, if you give them a lot of crystalloid fluids, when they try to pull everything back, they can't pull the gut back, so they have to leave an open abdomen, and they're in the ICU with an open abdomen packed. Well, they're seeing that without the crystalloids, without the ringers, without the normal saline, if they're given plasma or just blood products, then they're able to close the belly. I was talking to one of the trauma surgeons out in South Alabama several weeks ago. He said, we have not had an open injury since we went away from crystalloid in ages. He said, used to, we'd have to leave open bellies all the time because we were pouring these crystalloid fluids to them and just basically causing swelling. And he said, now that we're using fresh frozen plasma and packed red blood cells and what we call a massive transfusion protocol, he said, we're able to close it, which ultimately leads to better outcomes with the patient. So just things like that we really ought to embrace from a pre-hospital standpoint. So recapping a little bit, penetrating trauma, permissive hypotension, not blunt, not traumatic brain injuries, penetrating trauma only. 80 to 90 is a general rule. Shoot for that palpable radial pulse. If you can get to that point, you've done your job.
Interesting. So, and I'll ask this, so why do you ever see a time when ringers will come back to, because you always say don't throw away your bell bottoms, they'll be back in style. So do you ever see a time where ringers will be the fluid of choice for any type of trauma?
Already seeing it. DCH now, the trauma surgeons are using ringers again. So they're going with ringers. Lots of the burn surgeons use ringers. So right now, lots of the trauma surgeons, I won't say lots, but some of the trauma surgeons, especially DCH, they're starting to, not always, but they're starting to use ringers again. So yeah, we're starting to see that. You know, it's just the pendulum swings. You know, they want to use normal saline, and then they'll start to use ringers, and you know, and again, just as you mentioned, I tell everybody, don't ever throw your bell bottom blue jeans away because they're going to come back in style at some point in time. So yeah, we're starting to see that already.